Okay, let's have some fun. A little rapid fire here. Can we cure myeloma, Sagar?
We already are.
Ed?
I still think there's a bit of ways to go to get most of the patients cured.
Amrita?
I'd say yes with immunotherapy.
In who? All patients?
I think in all patients, because I think immunotherapy is risk agnostic.
All right, can we cure myeloma, Tom?
I think in frontline we cure maybe 10 to 15% of patients with a transplant. Whether we can cure them at relapse is still yet to be seen.
Did you?
I think, yeah, 10% of patients have not relapsed. Bart published this in Blood without any treatment in 10 years. So that's functional cure.
High risk as well, or just low risk patients?
Well, I think right now it's the hyperdiploid standard risk patients that are getting benefit from an auto transplant. I think with our new strategies, it's hard. I mean, so we looked at 1,000 patients at our center that got RVD, transplant, and maintenance. 70% are in remission or are alive at 10 years. 70%.
Do you tell your patients, I might be able to cure you, or are you more, we'll do the best we can, we'll see what happens?
I tell them that there is a fraction, 10 to 15%, and I'm doing my best to put them in that fraction.
What do you tell a high risk
I tell them
patient?
that I don't use the C word, but that I have patients who are decades out doing well.
Yeah, we all have them, but they're hard to identify in the beginning, aren't they?
You're right.
And okay, do we need MRD negativity to cure people?
So I would say MRD is here to stay. We're going to be testing it in myeloma more and more, and we're going to have more data to do risk-adapted changes in treatment. But yes, to be cured of myeloma, I think you have to be MRD negative for a certain period of time, whether it's 1 year or 3 years or 5 years. You know, that'll be
So you don't subscribe to the hypothesis you can turn people back to MGUS and they'll...
I do actually. So there is a small percentage of patients, maybe that's 5% of patients that have that residual MGUS clone. That's going to still be there 10 years later with an M protein of 0.5 or 0.7 and it isn't going to change. And we all have those patients that never got maintenance and their M protein is still 0.7 like 10 or 15 years down the line.
Do you think to cure we should be treating earlier, Ajai?
Well, I think to integrate those two questions, the limitations of MRDs, you really need to not just know the MRD status, but what's the bone status in terms of imaging, and also what is comprising that MRD positivity. When we looked at our patients who had known smoldering prodrome to those who didn't, the ones who had known smoldering prodrome didn't necessarily get into CR states, but they had a longer overall survival. So I think that speaks to your question. But treating smoldering, my problem with this is we need to, at the end of the day, have a randomized phase 3 study. And if we don't pick the right model, we're going to underpower these studies because not everybody with smoldering is going to progress. So if you start treating everybody, you're not going to be able to identify. And I personally believe that, in particular, the free light chain ratio and the bone marrow criteria are not perfect. And I think those patients that are currently being classified as myeloma are the very ones we should be studying in terms of treating early and not moving them into early treatment without
Anybody
studies.
disagree with this? Anybody think we should be treating all our smoldering myelomas to cure them?
I mean, if you look at the mutation burden of a smoldering patient compared with a newly diagnosed myeloma patient, it's identical. So what I worry about is interventions early may be suppressing the immune regulation that's keeping it in smoldering and not allowing it to progress to myeloma. And so you know, outside of clinical trials, I don't advocate for treating smoldering early.
So there are clinical trials underway, active, very aggressive treatment of smoldering myeloma, KRD, transplant, more KRD. What do you think of those, Ed?
Well, just like I have patients who are decades out from aggressive therapy and transplant, I have patients who are decades out with smoldering myeloma who I've just been monitoring and keeping our neurosis level low. And so, so I think we really need better prognosticators to really differentiate. What I always tell the patients is I don't want to treat you 3 years before you need treatment, but I want to treat you 3 months after you needed treatment. I want to treat you about like 6 months before you need treatment.
To echo your sentiments, I think this baseline risk stratification is really misleading because, first of all, we don't really know how long that patient's had the smoldering myeloma, and we just picked the time point as their first marrow. But what's really more important is the kinetics of the disease. And in our hands, when you compare the baseline criteria to the kinetics, which is evolving hemoglobin, evolving M-spike, evolving light chain, those are what really matter. And it's just like in CLL, the doubling time. And so I don't know why we've gotten lazy and just take the baseline and totally blind ourselves to what happens.
So it sounds like the consensus is smoldering myeloma treatment still belongs in trials and don't do it at home.
And I think the other misconception that's sort of been propagated is, looking at early breast cancer, DCIS.
Yeah.
But this is not DCIS, because the burden of therapy you're going to put on someone with smoldering myeloma is tremendous if you
Not
start.
to mention, we don't treat early MDS, CLL, or follicular, right? So we have a lot more in common with the heme malignancies than early stage breast and prostate and colon.